I'm Krista Harding. I am a senior manager on the community engagement team at the National MS Society. My focus is on pediatric MS and engaging with young people and their families who are affected by pediatric MS. I also would like to have you join me in welcoming Dr. Laura Saucier. Dr. Saucier is an attending child neurologist and assistant professor of clinical neurology at Children's Hospital LA and USC Keck School of Medicine. She obtained her Bachelor's of Science in Biology at Duke University, her Master's of Science in Global Health at the University of California, San Francisco, and her medical doctorate at Stanford University School of Medicine. She completed residency in child neurology at Stanford University and Lucile Packard Children's Hospital, Stanford, and a fellowship in pediatric multiple sclerosis and neuroimmunology through the Harvard Combined Program at Mass General Hospital, Brigham Women's Hospital, and Boston Children's Hospital. Her training has also included mentored research at the National Institutes of Health in Maryland, medical Spanish in Ecuador, clinical research on HIV-associated cognitive impairment in Kenya, and social determinants of health research in Tanzania. Her primary focus is providing compassionate, high-quality, evidence-based, and equitable care for children, adolescents, and young adults with neurologic disorders. Her clinical area of expertise is pediatric neuroimmunology, which includes a wide range of disorders, including MS. In addition to her clinical activities, she's also involved in medical education, clinical research, and health disparities work. She is particularly passionate about educating medical students, residents, patients, and families. When she's not working, she enjoys spending time outdoors with her husband and son. You can see from her background, she loves the mountains. She loves soccer, hiking and backpacking, rock climbing, trail running, skiing, and pretty much any other activity in the mountains. Welcome, Dr. Saucier.
Thank you so much for that incredibly kind introduction, Krista. So today we're going to be doing an introduction to pediatric multiple sclerosis. This is a topic that's very, very near and dear to my heart because I feel very strongly that as patients and families, you have every right to know and understand what's going on in your body. And therefore, I hope today that you might be able to learn and take something away about the biology of multiple sclerosis, what we know about what causes it, and how we treat it. So today, some things that we'll be discussing: what causes multiple sclerosis, what exactly is it, what are some symptoms that you may experience, how is it diagnosed, how is it treated, and then finally, what does the future look like for over the next few months and years. Before we get into that, I do want to make a note of the prevalence. In the United States, there are about 5,000 children and teens who are living with multiple sclerosis. So it's fairly rare. In my patient population, it's very common, but overall, it's very rare. There are more adults who do have multiple sclerosis than children. Now, what causes multiple sclerosis? We're going to get into some biology here. So I hope you're ready. The answer, though, the short answer is it's complicated and we don't fully understand what causes multiple sclerosis entirely. In general terms, we think of it as an interaction between our genes or our DNA and our environment that triggers or confuses our immune system, which then attacks our central nervous system. So first, the role of genes or DNA in multiple sclerosis. It's important to know that there's no single gene that causes multiple sclerosis. And likewise, there's no gene test that confirms multiple sclerosis. And although we know that genes play a very important role, it's important for you to know that if you have multiple sclerosis, your first degree relatives, so that means your mother, your father, a child, a sibling, their risk of developing MS, it's very rare. Only 2 to 5% of them will develop multiple sclerosis. So the vast majority of people living with multiple sclerosis do not have a first degree relative who also has multiple sclerosis. So environmental factors, right? We talked about genes and the environment. And so there's been a lot of research into environmental factors. And I wanted to focus on two of the most important ones. One of them is low vitamin D. So many of you, if you've been diagnosed with multiple sclerosis, you probably will have had your vitamin D checked. And your doctors will probably want to make sure that it's high or at least medium. And that's because we know that low vitamin D is associated with multiple sclerosis. And it seems like lower vitamin D can actually be associated with more relapses. So it's really important to get the vitamin D up. Another environmental factor that we think is very closely linked to multiple sclerosis is a virus. It's called Epstein-Barr virus. I don't know if anybody's heard of it. It's everywhere. It's throughout our environment. It's incredibly common. Almost everyone will be exposed to this virus, EBV, over the course of their life. And despite that, only a small percentage of those people will end up being diagnosed with multiple sclerosis. So just if the majority of these people in the picture do have an EBV infection, perhaps only one of them will end up diagnosed with MS. And so we have had some pretty groundbreaking research. It was published in 2022 that really supports that EBV is perhaps not just very important in triggering multiple sclerosis, but it actually may be necessary, not sufficient, but necessary for multiple sclerosis to develop. So now moving forward, what exactly is multiple sclerosis? Multiple sclerosis is an autoimmune and demyelinating disease that affects the central nervous system. Almost all pediatric onset multiple sclerosis is considered relapsing remitting multiple sclerosis. Now let's break that down. We're going to talk about each of the bolded terms. So explaining autoimmune disease. An autoimmune disease occurs when your immune system, which is supposed to be fighting viruses, bacteria, keeping your body healthy, when it becomes confused or overactivated. And when that happens, instead of just fighting the viruses and the bad guys, it can turn on the good guys, and it can also attack healthy parts of your body. And that inflammation and damage that the immune system causes, it causes symptoms. So different kinds of autoimmune disease affect different parts of the body. And in multiple sclerosis, this affects your central nervous system. And some of you may have heard a term lesion when your doctors are talking to you about your MRI, for example. A lesion just means it's an area of inflammation and damage that we can see on an MRI. So that's an area that we know has been affected by multiple sclerosis. We know that the immune system has gotten into the brain where it doesn't belong, and it has caused inflammation and damage. And that area of inflammation and damage is called a lesion. Lesions can come with symptoms. So sometimes you feel it and you have symptoms such as weakness. We'll discuss these a little bit more, but other times they're silent. So we talked about multiple sclerosis is an autoimmune demyelinating disease. So we talked about what autoimmunity is. Now we'll explain demyelination. I don't know if any of you have a cat. I do. And every time I think of demyelination, I think of the picture up on the screen right now, an iPhone charger. My cat chews on it. And when that happens, he chews the insulation around the wire and it doesn't charge very well anymore. That's essentially what demyelination is. So all of our nerves in our nervous system, they're wrapped around with an insulation called myelin. It's very important. It helps protect the nerve, but it also allows them to conduct their electrical signals effectively and efficiently, because that's how nerves talk to each other, right? They're sending electrical signals. So demyelination is when the immune system that we talked about before gets overactivated or confused and targets and attacks the myelin, the insulation around the nerves. And when that happens, the nerves have a hard time talking to each other, and you can have some symptoms from that. One of the important things to know is that myelin can repair. So when the myelin is damaged on a neuron, it can repair and rewrap itself. It might not do so perfectly, but it can repair. So we've talked about multiple sclerosis being an autoimmune demyelinating disease. Now I'm going to tell you what it means to affect the central nervous system. So we have nervous system throughout our body. We have peripheral nerves going to our fingertips. We have all kinds of nerves throughout our GI tract. But the central nervous system is referring to three parts of our nervous system: the brain, the spinal cord, and the optic nerve. The optic nerves are the nerves that travel from the back of your eyeball and go back to your brain and connect your eyes to your brain, carrying your visual information. So whenever there's inflammation in the brain from multiple sclerosis or any other autoimmune disease, the brain inflammation can be silent or it can cause symptoms. And that depends on the exact location of the lesion. Remember, a lesion is an area of inflammation. So for example, if there's a lesion or an area of inflammation on the right side of your brain, that controls your left hand, then perhaps you'll have some clumsiness or weakness of that left hand. In the spinal cord, we call inflammation of the spinal cord or lesions of the spinal cord, we call it myelitis. And symptoms we'll describe a bit later, but that can include things like numbness, weakness, tingling in your extremities, and sometimes bowel and bladder symptoms as well. The optic nerve. When we have inflammation in multiple sclerosis in the optic nerve, we call it optic neuritis. And usually that manifests as blurry vision and color changes. So perhaps not being able to see colors as clearly in one of your eyes. So I just wanted to show you something. I encourage you, if you're interested, to ask your neurologist to show you pictures of your MRI if you're interested. But I just wanted to give you an example of some of what we're talking about. So here are what we call lesions or areas of inflammation in the brain. Those are those white spots. Here's a spot, it's more subtle, but that's in the spinal cord. And then you can see that that optic nerve on is brighter than the other side. And so that's what we mean when we talk about lesions in these areas of the central nervous system. So now I want to talk about what it means to have relapsing remitting multiple sclerosis. What this means is there are periods of relapse and remission. So during relapses, there are new areas of inflammation, new lesions that arise intermittently, one here, one there, scattered throughout the central nervous system. And then there's healing. The inflammation reduces, a scar remains. So that scar remains on the brain, spinal cord, or optic nerve, but the inflammation goes down, you remyelinate, symptoms often improve, and then you enter remission. Sometimes areas of new inflammation can cause a clinical relapse, and that means that you have new symptoms. So again, the same example as before, if you have a new lesion on the right side of your brain that controls your left hand, then you might have left hand symptoms. However, there are some times when there might be a new lesion in your brain that's silent and it's hiding and you don't feel any symptoms. I want to show you a graphic. It's a little bit of a busy slide. This is something that I show my, my neurology residents and trainees to explain what happens in relapsing remitting MS. You can see that there's arrows on the bottom. Those are new lesions or areas of inflammation that arise on the MRI. And the brown or tan line, over time, those lesions, those scars build up, right? And that's considered the disease burden. And then superimposed upon that, you can see that some of the lesions we see on MRI generate symptoms, and that's that green line, and that's a relapse. And over time, some relapses you return entirely to baseline. So you have symptoms and then they go away completely. Other times you have symptoms, afterwards you experience significant improvement, but you may not return all the way to baseline. So that left hand that was clumsy, you might get it almost completely back to normal, but it just doesn't feel quite the same as it did before. And I do want to make one point before I leave this slide. This is the natural history of multiple sclerosis when we don't treat it. And so later we're going to talk about treatment and how we can stop this process in its tracks, which is something we didn't used to be able to do, but we can do now. So what are some symptoms of multiple sclerosis? The way I think of it, I think of focal neurologic symptoms and I think of non-focal neurologic symptoms. These are words that neurologists use, so I want to introduce you to them. Focal neurologic symptoms mean that you have symptoms that are caused by a specific new or old area of inflammation or a lesion. So again, going back to the prior example, if you have a lesion on the right side of the brain that affects that left hand, that weakness in that left hand, that's a focal symptom. That's caused by a specific lesion. And then there's non-focal symptoms. So non-focal symptoms can also be associated with multiple sclerosis, but not with a specific lesion. And we'll talk about what those are in a bit. So first, focal neurologic symptoms. Again, these are symptoms that depend on the location of the lesion for what symptoms are produced. And if you have brand new focal neurologic symptoms, especially ones that are lasting for more than 24 hours and getting worse, especially, that could indicate a new relapse or a new lesion. It is important to know, though, that old symptoms of old lesions, those can come back when your body's under physiologic stress, when you have a fever, when you're very tired, when you're very stressed, and then also specific to multiple sclerosis in the heat. So many of my patients they can't stand the heat. It makes some of their old symptoms come back. And there's a phenomenon called Uthoff's phenomenon, and that describes that that the old symptoms coming back. So some focal neurologic symptoms that we need to watch out for, things like blurry or double vision, slurred or abnormal speech, a facial droop, balance or coordination issues, focal or weakness or numbness. And by focal, that means it's not the whole body all of a sudden feeling numb or the whole body feeling weak or tingly, but it's a specific arm or specific leg, perhaps both legs. It's focal rather than generalized. And then rarely urinary problems can also be a focal neurologic symptom in multiple sclerosis. Usually that's when there's a spinal cord problem. I don't want you to think though that any urinary problem that you may have is necessarily related to MS. There are other reasons for that as well. I included the graphic below. It's the swimming pool analogy. I like it very much. It just shows basically the symptoms that you experience are when the I don't know what to call them, the little protrusions stick above the surface of the water, but beneath the surface of the water, there are silent lesions too. So non-focal multiple sclerosis symptoms are very important to talk about. These are not symptoms that usually indicate a new relapse. They are non-focal. They are not because of a single lesion, and therefore, when they arise, it doesn't necessarily mean there's a brand new lesion. Sometimes it does, but usually in conjunction with focal neurologic symptoms. So in general, some of these symptoms may include fatigue, depression, attention or focus problems, or sometimes memory or learning concerns. Many of these symptoms can be addressed and managed with your healthcare team. Next, we'll talk about how multiple sclerosis is diagnosed. Many of you have probably been through this already, so you'll know that we diagnose multiple sclerosis based on symptoms, a neurologic exam, an MRI, sometimes a spinal tap, and one of the tests we're looking for in that spinal tap is something called oligoclonal bands. So you may have heard of that. I want to introduce you to the term. Not everyone who has multiple sclerosis will have oligoclonal bands in their spinal tap, in their spinal fluid, but it is one sign that points strongly, but not 100% of the time, to multiple sclerosis. And then of course, it's important to look at blood and spinal fluid labs to make sure that we rule out things that can mimic multiple sclerosis as well. So how and why do we treat multiple sclerosis? Well, we treat it in two different ways. First, we treat acute relapses. So remember that left hand is clumsy and it's weak. You may receive 3 to 5 days of high dose steroids to help improve those symptoms. And what those steroids does is it takes the inflammation and it brings it down in order to allow the nerves to repair and the myelin to start regenerating. In addition to treating the acute relapses, we want to prevent future relapses, right? We want to prevent future lesions, future areas of inflammation, future symptoms, any future disability. And the way we do that is by using something called disease-modifying treatments or disease-modifying therapy, and that prevents future relapses. Disease-modifying therapies work by controlling or suppressing that overactive immune system that causes problems. And it prevents it from attacking your nerves and your myelin. One of the things I really want to be a big take-home point is there has been tremendous progress in multiple sclerosis treatment in the last 10 to 20 years. It is an absolute privilege to be able to work in this field because we have excellent medication that can make an incredible difference in the lives of our patients. We have excellent treatment that can prevent any further inflammation, nerve damage, or relapses. Unfortunately, we still don't have treatments to reverse the old damage. Scientists are working on it. They're working on it really hard. I know some of them personally, but we still don't have treatments that reverse those old lesions, that heal those old scars. And so it's really important that we use these disease-modifying therapies to prevent any future damage. And one thing I want to point out is that many of my patients say, you know, I'm taking this disease-modifying therapy, this DMT, I'm not feeling any different. And usually I say, good, that's fantastic. That's what I want. I don't want you to feel different in the sense that I don't want you to have side effects. But in addition, I don't want you to have a new relapse. So our disease modifying therapies don't reverse old symptoms. They don't reverse old damage, but they prevent new damage from happening. So when my patients tell me that, I say, I'm very glad that you're not having new symptoms. That's the goal of these new DMTs. However, we still need to work on managing some of the symptoms that happened because of the old damage. So remember this graphic. We have this process where there's new inflammation over time that comes and goes and comes and goes. And with that inflammation, sometimes there's symptoms or relapses. Disease modifying therapies stop it. It stops the relapsing in its tracks. And I actually should have those arrows covered up as well with this graphic, because not only does it stop the clinical relapses, but our strongest medicines do a very good job at also significantly reducing and sometimes stopping altogether the inflammation or lesions from building up on the MRI. So the next logical question is probably, well, it sounds like DMTs are great, but which ones should I select? Because there's many good DMTs out there now. And there's no one size fits all answer. It's a very personal decision between you, your family, and your doctor. I've listed here some of the considerations that we use when we make these decisions, but I highly encourage a shared decision making between patients, their families, and doctors. So some things we think about are MS severity. More severe disease, you may require stronger treatment. Side effects are something to consider as well, and risks. So many of our disease modifying therapies, they work by reducing an overactive immune system, right? By suppressing it. And when we suppress an overactive immune system, sometimes that immunosuppression can leave patients more susceptible to infections. And so that risk versus benefit is something that we have to consider. And we also have to realize that people have different perspectives on the relative risk of immunosuppression and other MS treatment side effects, and also different perspectives on the relative risk of an MS relapse, because there's always a trade-off between preventing MS relapse and avoiding MS treatment risks. General health and lab results are other important considerations, because we want to select a disease modifying therapy for you that is safe for you. So there are certain comorbidities or certain lab results that mean that there are certain treatments that may not be particularly safe for you. So methods of administration is another consideration. And many of my patients feel very strongly about the way that they receive their medication. So there are different ways. Some medications are at-home injections, others are oral tablets, and others are infusions. The infusions, for the most part, are either once a month for one medicine or every 6 months for a couple others. And then barriers are something very important to consider. But there are ways to address these barriers that Krista will talk about briefly at the end of this program. But things to consider are financial burden, insurance problems. Some patients don't live particularly close to an infusion center, or it may be logistically very difficult to come for frequent infusions. And then it's also important to consider whether or not you're someone that would do well taking a medication consistently every day or not. So how do we treat multiple sclerosis? These are a lot of different medications. I'm not going to go through them all in detail, but I just want to let you know that in general, these are some of our choices when we think about which medication to start. And as a general rule, as the effectiveness or the strength of those medications increase, so the medications that are the strongest at preventing multiple sclerosis, those also tend to be the ones that carry the most risk of immunosuppression or other risk. So as the effectiveness increases, unfortunately, so does the risk. And that gets down to where it's so important to find that right balance for you by talking to your doctor. The least effective and oldest multiple sclerosis medications are the ones bolded here. They're at-home injections. They are low risk, but sometimes they carry side effects that can limit your ability to tolerate them. So things like injection site discomfort or reaction and flu-like symptoms. So even though these are our lowest efficacy treatments and our oldest treatments, that doesn't mean that they don't work for some people. There are some people that this might be all that they need to keep their multiple sclerosis under control. Again, it's trying to match your multiple sclerosis and you with the right treatment for you. Going up a little bit more effective, we have oral tablets, and these are moderate efficacy. They're generally relatively low risk. Sometimes they have side effects, especially GI side effects. So things like abdominal discomfort that can sometimes limit tolerability. But these are overall pretty good medications, and they're ones that can control multiple sclerosis pretty well in a good number of people, but not in everybody. These are another type of oral tablets. They're called S1P modulators, and there's a group of them. They're all cousin medications. I bolded and put a little star next to fingolimod. It's also called Gilenya. This is one that I really want you to know about because it's the only FDA-approved medication for pediatric multiple sclerosis. Many patients ask me, well, then that must be the medication that I have to choose. And that's not always the case. So the reason that it's the only FDA-approved medication is not because it's the only safe or effective multiple sclerosis medication. We use all the medications that I have listed here, but it is the only one that has had enough clinical trial data to support an FDA approval. And as we went through on one of those first slides, the prevalence of multiple sclerosis, there are not many children and adolescents with multiple sclerosis in the United States. So it's really hard to find enough patients to have large enough clinical trials. So we are very lucky that we have one FDA-approved medication, but it is not the only medication that is safe or effective. We use all of these. This group, the S1P modulators, fingolimod or Gilenya included, they're oral tablets, they're highly effective, and they usually have low to moderate risk for young, healthy patients. I want to let you know how they work. And obviously, we're not going over extensively all the side effects. I leave that to a discussion with you and your doctor, but I do want you to have an understanding about how this group of medications work. It traps certain immune cells called lymphocytes. So you may have heard of B and T cells. Those are lymphocytes. And it traps them in your lymph nodes. And it does so that they cannot go into your brain where they don't belong and attack your brain and cause inflammation. So you trap them in the lymphocyte in the lymph node jail. And it's very important that these medications that you take them very consistently because you do not want a jailbreak. You do not want those lymphocytes to bust out of jail and get into your brain because that can lead to a really big relapse. So for these medications in particular, making sure that you're very consistent taking these medications is absolutely critical. Natalizumab, it's also called Tysabri. This is the monthly infusion. It is exceptionally effective, very good at stopping any relapses. And in many patients, they don't even have any new spots on their MRI. It is a high-risk medication for patients that are JC virus positive, but it is quite low risk in patients that are JC virus negative. I'm going to tell you a little bit more about JC virus just briefly, but first, I want you again to know how this medication works because it's an important one. This medication prevents immune cells from entering the central nervous system. So your lymphocytes, remember those pesky cells that can get into your brain and cause inflammation. Those lymphocytes are traveling through your blood vessels, and then they get to your blood vessels in your brain, and then they attach themselves and kind of squeeze out and go into the brain. And that's how they can create inflammation. This medication prevents them from attaching to the blood vessels so they can squeeze into the brain and cause problems. It's incredibly effective. But the one thing to realize is since immune cells can't get into the brain to cause inflammation, they also can't get into the brain to go on their normal patrols of the brain to make sure that the brain is healthy and infection free. This leaves a risk of brain infection, but one brain infection in particular, and it's called PML. It's a very serious brain infection. It's caused by JC virus. So in patients who have had JC virus, they've been JC virus exposed, and we test for this in their blood, it's a high-risk medicine for them. But patients that are JC virus negative, this is a safe medicine for them because their risk of that brain infection called PML is less than 1 in 10,000. Lastly, B-cell depletion therapy. There are a number of different agents and more are being approved. Rituximab, ocrelizumab, also called Ocrevus, and ofatumumab, also called Kesimpta. The rituximab and ocrelizumab, those are every 6-month infusions. Ofatumumab is an injection that you give at home. These are exceptionally effective medications. They're generally moderate risk, and that risk is mostly related to immunosuppression. But most pediatric multiple sclerosis patients are young and healthy, and most of them do very well with these medications. The way that they work, they destroy one particular type of lymphocytes that cause the inflammation in multiple sclerosis. They destroy B cells. And the reason that they're dosed every 6 months is because these medications destroy the B cells that are circulating in your blood, so they can't cause problems. Very effective treatment. But the baby B cells are still alive and well in your bone marrow, and they grow up over the course of several months. And usually they start entering your bloodstream as grown-up B cells around 6 months. So that's why you get this medication every 6 months. All right, so now you've been diagnosed with MS, now what? The goal is no more relapses and no more lesions, because that's what over time can build up to cause disability. But it's also important in that as we try to give you medication to stop relapses and lesions, we don't lose focus that we also need to treat and manage your current symptoms, because it's one thing, it's fantastic and a big goal for us to prevent any future inflammation, future disability, future symptoms. But we still need to focus on, manage, and help you treat your current symptoms, because we want you to have a full and wonderful life at home, school, and wherever you go. So you and your family will partner with your neurologist to select the right disease-modifying therapy or DMT for you. And then afterwards, you'll get routine MRIs and neurologic examinations to monitor the stability of your multiple sclerosis. You'll also, depending on the DMT selected, you'll also likely have blood tests intermittently to make sure that whatever disease-modifying therapy you're on remains safe for you. And if there are relapses or new lesions, you may need to change to a different or stronger disease-modifying therapy to prevent further lesions and accumulation. So also wanting to address and treat symptoms that you have, and we do so with a big care team. So your family, your pediatrician, your neurologist. Many of our patients also have an ophthalmologist, an eye doctor, a neuropsychologist might be part of their care team. A therapist or a psychiatrist may also be part of the care team, particularly because depression and anxiety are very common in our patients with multiple sclerosis. Physical or occupational therapist, and sometimes a urologist as well. We're all here for you to help manage your symptoms. So in summary, MS is a serious condition, but it's very treatable. It's very treatable today. We couldn't say that a decade or two ago. We couldn't say that 2 decades ago. Now we have excellent treatments. And with effective treatment, it's possible that you may never have another relapse or disability in the future. There's a lot of reason to be hopeful. There are more and more discoveries every year, and in your lifetime, there may be a cure. So I want you to know that a diagnosis of multiple sclerosis doesn't define you. It shouldn't limit your plans for the future, and you can live a very happy and a very full life. And with that, I'm very happy to take any questions. And again, thank you for having me here. It's truly an honor and a privilege to be talking to you today.
Thank you so much, Dr. Saucier. That was a really great presentation, and you broke down some of those concepts in a way that was really easy for me to understand. So I hope that that was the same for everyone in attendance tonight.